If you are on blood pressure medication right now, what I'm about to tell you in the next few minutes could genuinely save your kidneys or your life. There are two specific types of blood pressure pills that are being prescribed together to seniors across this country every single day. Millions of people are taking this combination right now, following their doctor's instructions, believing they are doing everything right. And quietly, without any obvious warning signs, their kidneys are being damaged, their blood pressure is swinging dangerously low, and their potassium levels are creeping toward a level that can trigger a cardiac emergency. The evidence against this combination is so overwhelming that the FDA issued a specific safety warning about it. A landmark study involving more than 25,000 patients had to be stopped early because the harm became impossible to ignore. So, if you are on more than one blood pressure medication, and especially if you are over the age of 60, you need to watch every second of this before you take your next pill. I'm Dr. Sarah Mitchell, and this channel is dedicated to giving adults over 60 the kind of clear, evidence-based health information that a rushed doctor's appointment rarely has time to cover. If this is your first time here, please subscribe. We cover topics every week that directly affect your health, your medications, and your quality of life. Now let me tell you exactly which two medications we're talking about and why their combination is so dangerous for aging bodies specifically. The two types of blood pressure medications you must never take together are ACE inhibitors and ARBs. ACE stands for angiotensin-converting enzyme inhibitor. ARB stands for angiotensin receptor blocker. You do not need to remember those names. What you need to remember are the specific drug names, so you can check your own prescriptions today. Common ACE inhibitors include lisinopril, enalapril, ramipril, and benazepril. Common ARBs include losartan, valsartan, telmisartan, and olmesartan. Go ahead and pause this right now if you need to check your medicine bottles. I will be here when you get back. If you find one name from each of those two lists in your medication drawer, this video was made for you. Here is why combining them is so dangerous. Your kidneys have a built-in pressure regulation system called the renin-angiotensin-aldosterone system, the RAAS system. Think of it like a control valve that your kidneys use to manage blood pressure throughout your body. ACE inhibitors work by blocking one part of that valve. ARBs work by blocking a different part of the same valve. When you take both at the same time, you are essentially putting two hands on the same control dial and wrenching it as hard as possible in the same direction. On paper, that might sound like it would lower blood pressure more effectively. In reality, the results are catastrophic. The evidence came to a head with what is now considered one of the most significant cardiovascular trials in modern medicine. The ON-Target trial, the ongoing telmisartan alone, and in combination with ramipril global endpoint trial, enrolled 25,620 patients with cardiovascular disease or high-risk diabetes. Researchers specifically designed it to test whether combining an ACE inhibitor and an ARB would produce better outcomes than using either drug alone. The study was published in the New England Journal of Medicine in 2008, and what it found changed prescribing guidelines worldwide. The combination group did not experience fewer heart attacks. They did not have better blood pressure numbers, but they had a dramatically higher rate of acute kidney injury. They had nearly 3 times more episodes of dangerously low blood pressure, a condition called hypotension that left patients dizzy, faint, and at risk of catastrophic falls. And their potassium levels rose to dangerous, potentially fatal levels. The scientific community and the FDA responded with formal warnings. The American Heart Association and the American College of Cardiology updated their hypertension guidelines to specifically advise against this combination. And yet, a study published in the Journal of the American Geriatric Society confirmed that a significant percentage of older adults are still being prescribed both medications simultaneously. Comment below right now and tell me how many doctors are currently managing your blood pressure or heart health. Whether it's 1, 2, or 3 or more, that number matters more than you might think. Here's the part that makes seniors specifically vulnerable, and this is something I want every person over 60 to understand deeply. As you age, your kidneys naturally lose filtering capacity. By the time a person reaches their late 60s, kidney function has typically declined to somewhere between 60 and 75% of what it was at age 30. This is completely normal. It is not a disease, but it means your kidneys are working with less reserve. A medication combination that a 45-year-old might tolerate, however imperfectly, can push a 70-year-old's kidneys into acute injury within months. That injury often has no dramatic symptoms, no pain, no sudden crisis that sends you to the emergency room, just a slow, quiet decline in kidney function that you might not notice until the damage is already significant. A 2019 analysis published in the journal Pharmacoepidemiology and Drug Safety found that seniors on dual RAS blockade, meaning both an ACE inhibitor and an ARB at the same time, had a 2.5 times higher risk of dangerous hyperkalemia compared to seniors on a single agent. Hyperkalemia means excess potassium in the blood. And here is what makes that terrifying. High potassium often produces no symptoms at all until levels become critical. You might feel mild muscle weakness, some unusual fatigue, a vague sense that something is off. But for many people, the first real signal is a cardiac arrhythmia, an irregular heartbeat, or worse. I want to tell you about Frank. Frank is 71, and he came to my office after nearly a year of crushing fatigue that nobody could explain. His primary care doctor had run thyroid tests, checked him for anemia, and suggested he was just experiencing normal aging. But when we sat down and went through his complete medication list, not just what his primary care doctor had prescribed, but everything from every specialist, the answer became clear immediately. His cardiologist had prescribed lisinopril 3 years earlier for mild hypertension. His nephrologist, a kidney specialist, had added losartan 8 months ago without realizing Frank was already on an ACE inhibitor. 2 excellent doctors, no communication, 1 dangerous combination. Frank's kidney function had deteriorated measurably. His potassium was elevated. Once his medications were carefully restructured under supervision, transitioning him to a single, appropriately dosed ARB over several weeks, his kidney numbers stabilized within 4 months. His energy came back. He told me he felt like himself again for the first time in a year. Now, before I give you the exact action steps to take this week, I need to cover one more dangerous combination that is increasingly concerning cardiologists, especially for seniors on heart rate medications. This one surprises even some physicians when they hear the data. Certain beta blockers, medications like metoprolol, atenolol, and carvedilol, when combined with a specific class of calcium channel blockers called non-dihydropyridines, which includes verapamil and diltiazem, can cause your heart rate to drop to life-threatening levels. Beta blockers slow the heart's electrical signals. Verapamil and diltiazem slow those same signals through a completely separate mechanism. Together, they can produce a condition called complete heart block, where the coordinated electrical signaling that keeps your heart beating in a proper rhythm simply breaks down. Symptoms include sudden fainting, profound dizziness, extreme breathlessness, and severe exhaustion. This combination has a legitimate use in very specific, closely monitored hospital settings, but it should almost never be a long-term outpatient prescription for someone over 60. If you are currently on any beta blocker and have recently been prescribed verapamil or diltiazem, put a call into your doctor's office today. Here is your exact action plan, and I want you to do every step of this within the next 7 days. Step 1. Pull together every single medication you currently take. This includes prescriptions from every doctor, over-the-counter medications, and any supplements. Write them all on one sheet of paper. Look specifically for any ACE inhibitor, lisinopril, enalapril, ramipril, or benazepril, paired with any ARB, losartan, valsartan, telmisartan, or olmesartan. If you find both on that list, call your primary care physician today and say these words. I've recently learned that combining an ACE inhibitor and an ARB is not recommended for people over 60 people. Can we review my blood pressure regimen? You are not being difficult, you are being informed. Step 2. Ask your pharmacist for a complete medication interaction review. This is a free service at most major pharmacies, including CVS, Walgreens, and independent pharmacies. Your pharmacist will run your full list through an interaction checking system and flag anything that concerns them. It takes about 15 minutes, and it is one of the most underused safety tools available to seniors. Step 3. If you have not had kidney function and potassium levels checked in the past 12 months and you are currently on blood pressure medication, ask your doctor to order a basic metabolic panel. This simple blood test checks your creatinine, which reflects how well your kidneys are filtering, and your potassium level. These 2 numbers will tell you whether your current medications are silently causing harm. Step 4. Do not stop any blood pressure medication on your own without medical supervision. This cannot be stressed strongly enough. Stopping these medications abruptly can trigger a dangerous rebound spike in blood pressure that increases your risk of stroke. The goal is not to stop your medication. The goal is to ensure you are on the right medication in the right combination. Any transition must happen gradually with monitoring under your doctor's direct guidance. Step 5. If you see multiple specialists and your medications are being managed by more than one doctor, request that your primary care physician serve as the central coordinator for your medication list. Ask explicitly, is everyone who prescribes for me aware of my full medication list? In an ideal system, that communication happens automatically. In practice, it often does not, and patients over 60 who see multiple specialists are at the highest risk for exactly the kind of dangerous drug combination we talked about today. What is your current blood pressure medication? Drop it in the comments below. Just the name. You might be surprised how many other viewers are on the exact same prescription, and your comment could help someone else realize they need to check their own regimen. This is the kind of community conversation that actually saves lives. Eleanor was 68 years old when she finally understood why her legs had been swelling every afternoon for almost 2 years. Why did she need to sit down after walking to her mailbox? Why her lab numbers had been quietly worsening with every blood test, and nobody had ever connected the dots for her. She had been on both enalapril from her cardiologist and valsartan from her primary care doctor for 18 months. The combination was affecting her kidneys. Once her physicians coordinated and transitioned her to a single ARB at an appropriately adjusted dose, her swelling improved within 6 weeks. Her lab values stabilized. She sent me a card that said she wished someone had told her sooner. That is the entire reason this channel exists. Here's the simple truth that every senior on blood pressure medication deserves to hear. 2 medications that work through the same biological system do not produce double the benefit. They produce double the risk. The on-target trial proved that beyond any scientific doubt. Major guidelines confirm it. The FDA has warned about it. And the right prescription for your blood pressure is the one that controls your numbers while protecting your kidneys, your heart rhythm, and your quality of life. Not the one that simply looks more aggressive on paper. Review your medication list this week. Ask the questions your next appointment might not have time for. And know that the few minutes you spend to take could protect the health you are working hard to preserve for the years ahead. If this video gave you information you needed, comment checking my meds right now, and please share it with anyone you know who is managing blood pressure after 60. Subscribe to this channel if you haven't already, because next week we are covering the #1 mineral deficiency that causes blood pressure medications to stop working. And it is one that most doctors never think to test for. I'm Dr. Sarah Mitchell. Stay informed, stay proactive, and I will see you in the next one.